team and the Hatch planning team. So I'll be monitoring the session for today, and I'm pleased to introduce you to Ann Ottney with the College of Pharmacy at FSU to present the Pharmacist integration into mental health collaborative care team. There you
Perfect.
go.
Awesome. Thank you so much. Feels very official. So thank you. And thank you everyone for zooming in this afternoon. I know it's been kind of a long day, but I'm hopeful and excited to share a little bit about an opportunity I've had over the last couple of years to really help improve the care of patients with mental health conditions, and also to provide meaningful experiences for our pharmacy students through the College of Pharmacy as well. So my only objective in this presentation is just to kind of provide some guidance on a model that I've found helpful within our clinical practice site, which I'll describe in more detail in just a minute here, to provide care to patients with complex mental health needs within a primary care setting, not a specialty care type of setting. And in case you haven't heard, mental health conditions are on the rise, and the COVID-19 pandemic has just really burdened the system more than it was before. As I was kind of doing a little research on background information for this presentation, just looking at the number of people in the United States that report having anxiety or depression, the numbers have increased dramatically in the last year alone. So with anxiety disorders, prior to 2019, we used to say about 8% of the population reported having some sort of anxiety disorder, and that number has now tripled to about 24% of people reporting some sort of anxiety disorder. Also, depression has increased, and so what used to be around 6.5% of the population that reported having major depressive disorder, we now have about 24% of the population reporting that too. And also suicide is on the rise, which is really a concerning consequence of untreated mental health and untreated mental illness in the United States as well. And so that's where this discussion I'm going to have about how we can maybe help patients with these conditions is really important. So what we know from the data right now is that a large number of people living with mental illnesses really don't get the care that they feel like they need. They may have difficulty accessing services for a variety of reasons. There are a shortage of mental health care providers to go around. It may be where they live in terms of transportation, or just generally not being knowledgeable about how to get into the system to get the help that they might need. So about 57% of people with mental illness state they don't get the care they need, and about 30% of people who have a serious mental illness, so someone with bipolar disorder or schizophrenia, report they don't feel like they get the care they need either. So there's lots of room for improvement on how to think about increasing services to this population. And as I was kind of trying to focus my presentation more on the role of pharmacists and pharmacy students within the care of patients with mental health conditions, there are many articles, and the literature is actually quite rich in terms of examples of pharmacists helping on mental health teams. Pharmacists bring to the table a wide variety of knowledge, not only about the pharmacotherapy for the medications that might be used for these conditions, but also to think about drug interactions, to think about monitoring parameters that we need to be following, and even to think about cost and access of the medications. Just because something is available certainly doesn't mean it will be affordable or accessible for a patient. So there are many examples in literature of pharmacists serving on mental health care teams. But what I found interesting as I looked through a meta-analysis that kind of tried to capture all the literature that's been published to this point is that many of these studies focused primarily on depression and were exclusive to just helping patients with depression, which is great, but it certainly excludes a lot of patients who really might need more of that team-based kind of care. So I think that's an important thing to kind of keep in the back of our mind. Also, interestingly, a lot of the research that's out there right now comes from Veterans Affairs facilities, which makes sense. That is a population where there are a lot of mental health issues, and so that certainly makes sense, but it does kind of limit the generalizability of the role of the pharmacist on a mental health team outside of that population. Something else I thought was interesting evidence or literature that's been published is that in several of the examples, pharmacists were kind of working more on their own through a collaborative practice agreement with prescribing of some of these medications, or maybe pairing with a physician or maybe a psychiatrist here and there. But something I'll talk about today that I didn't see in these articles was the inclusion of social workers in this team. And social workers are absolutely, at least with the patients we see, the eyes and ears and an advocate really for the patient and the needs that they might have. And so that was one thing that was also missing from some of the literature that I've seen about the role of the pharmacist on a mental health team. So I'm going to talk a little bit now about I don't know if it's an innovation is the right word, but what's the process that I've been involved with over the last couple of years, incorporating myself as a pharmacist and student pharmacist into the care of patients with complex mental health needs. And so just to set the stage, I currently have a practice site at the Sparrow Family Medicine residency clinic down in Lansing. We have a large number of medical residents and attending physicians that are employed at our two sites, one being in Lansing and one being in Mason, Michigan. And all in all, we see about 20,000 unique patients in total per year between these two sites. We're also lucky enough to have 3 licensed medical social workers that are available between our two offices, which is a wonderful service, as well as a nurse care facilitator, and then myself as the pharmacist to kind of cover both of these offices. So our practice offers a relatively large population to work with. We have a diverse set of patients, age, race, gender, socioeconomic status, all of that. So it does bring its challenges and its rewards. But what I'm going to talk about today is kind of the starting of this process of putting together a team of help patients with complex mental health needs. And so this started back in about 2018, kind of being spearheaded by our director of social work within our office, who we've had for many years a collaboration with a psychiatrist who works in the community, and kind of putting together a collaborative care model to try to improve, provide a safety net and improve the care of patients in our offices who have complex mental health needs. And so thinking about patients who the doctor feels overwhelmed by their mental health needs, feels like they're out of options to try to offer in terms of medications for the patient, or feels like they need help in terms of linkages to resources or otherwise. So for several months in 2018, the team has consisted of the licensed medical social workers and the psychiatrist meeting once a week. Usually we do it every Wednesday afternoon for about 3 hours, where we meet and review patients together. But it started out with just those kind of 2 groups. And it quickly became obvious as I was being asked questions or asked to follow up on things that it would be very helpful as a pharmacist to be included on the team and to start to meet with the team every week. And so over the course of the last couple of years, our team has really grown to now include not only the social workers and the psychiatrists, but myself as a pharmacist, and then student pharmacists who are on rotation also meet with the group. We also have the nurse care facilitator who's able to come and be a part of the team. And then as it pertains to a specific patient being reviewed, the primary care provider for that patient will often drop in to our meetings to provide their insight on ideas for medications or things that went well or didn't go so well for the patient. And of course, as with anything as it relates to healthcare, patients are not technically in our meetings with us, but they are at the center of what we are doing and trying to keep that patient-centeredness in mind as we're talking about the patients and what might be best to try to help them. So the process, so the way this kind of works is that the patient's primary care provider maybe sees the patient in the office. They could be a patient they've seen for a really long time, or it could be a relatively new patient that they might be seeing. And at any point in the process, in seeing these patients, they might feel like they need help. They might feel like they're out of options for medications, for the patient. They might just see the patient maybe has a more serious mental illness like schizophrenia and feel uncomfortable managing that on their own. So for whatever reason, the provider or the primary care provider is kind of the trigger to refer the patient to our team. And this all occurs either in person with warm handoffs or through our electronic medical record. And then once the patient is kind of referred to us, we get permission from the patient to enroll them in this collaborative care process. And they do an initial intake visit with our licensed medical social worker, who gets a little bit more of a background on their history of mental health conditions, their previous treatments, their previous therapists or psychiatrists that they maybe have seen. And then within the last year, as the pharmacist, we've kind of been pulled in to do the med intake. So our job, which I usually assign students to do if they're available, is for us to deep dive into the chart, look and see what we can find in terms of medications patients have been on in the past, and also to call the patient or meet with them in person to do a deeper dive into medications they maybe have tried if there's something we did not see in the chart, or to clarify information that we've found in the chart. So we do a pretty thorough initial intake to try to get a good history on the patient, to try to fill in any gaps as that helps us move forward. And once the patient is enrolled into the collaborative care model, they get put onto a registry, which we're able to pull reports from our registry in our electronic health record. It shows us the patient, it shows us the date they were last reviewed. It also shows us important markers we might look at for patients with mental health conditions like a PHQ-9 if they've got depression, or a GAD-7 if they have a history of anxiety, so we can look at trends in those as well. So we use that registry as a way to kind of determine which patients need to be reviewed. And in general, we typically review about 6 to 7 patients every week. And during these reviews, we basically, the social worker kind of introduces the patient. We kind of all are able to speak up and provide input as far as medication regimens or situations in terms of more of kind of the social situations the patient might be in, and kind of strategies to help guide them through, and to help improve their mental health overall in general. And then after that weekly meeting, we kind of decide as a team when it would be best to review that patient again. So really we try to keep track of all of our patients and keep up on them. And then every now and then, whether it be the patient doesn't need our help anymore, perhaps the patient has improved to a level where they just don't really need us to review their case every month or every few weeks anymore, we may actually put them in an inactive status on our list. So patients do graduate kind of out of the program every so often. But generally speaking, we have about 40 to 45 patients on our registry at any given time. And we're kind of constantly introducing new patients and removing old patients from that registry. So it's a bit more of a dynamic process with that. I thought it would be helpful to maybe just talk about a few examples of how pharmacists and the pharmacy team can be helpful in terms of things that we've done with patients who've been enrolled in this collaborative care model. So one of the examples that stands out to me was a younger patient in his 30s with schizophrenia, who had not previously been on consistent doses of his medication because he didn't like to take medication every day, and just felt a burden by the number of pills he had to take. And so through this team, we were able to identify a way to get him an injectable dose of a medication that he could just get once a month, and we could administer it at the clinic. Which worked out really well. And we were able, it's not just like you put them on the dose and they're good to go. This particular patient, we found out he was maybe metabolizing the drug or moving through it a little bit more quickly than most patients would. And through the expertise of our psychiatrist, we're able to figure out a slightly modified regimen where he got it at a different schedule than most patients would. And so that really helped him a lot to be able to be more functional in his life. And he did have schizophrenia, so we ultimately helped him transition to some some services that are probably more appropriate for someone with schizophrenia going forward. And so our part of that process was also to make sure he was able to stay on the Abilify at the dose he had been getting before and kind of carry him through that. Within the same patient, this is a medicine that can actually worsen some different lab levels like cholesterol, for example. And so with the pharmacy team, we were able to identify we should be monitoring these cholesterol levels and then to make a recommendation as far as providing a medication to help bring those levels down a bit as well. So there's lots of things that we were able to help with that patient. Something new that I've just started to dabble in a little bit, if anyone is on the line who has more expertise in this, then I would be very curious about their input. Just recently started to use a little bit more pharmacogenomic testing, and there's not a lot of great evidence for this in terms of its role for patients and some of the antidepressants or antipsychotics that patients might be on from a clinical perspective. But this is an area we're doing a little bit more of in patients who've maybe tried and failed a multitude of medications, and we're thinking maybe there's something about the way they're metabolizing drugs that might be why they're not agreeing with that patient. So this is an area we're just starting to explore, and between myself and a pharmacy resident and pharmacy students, we've been able to figure out what are the databases or systems we can use to order these tests, what tests do we need to order. They can help fill out the history of meds the patient has tried. So there's a lot of different areas for the students to be involved with there. And then adverse effect monitoring, like I mentioned already, for many of these patients who are on antipsychotics, we have to be looking at their blood sugars and their cholesterol levels and making sure they're up to date on their labs. And that's something that maybe would get missed if we didn't have the pharmacy group on the calls. And so that's been something else we've been able to help with. Something else that's not on here that we certainly do a lot of, especially with the students, is just general drug information questions. So really having the students take that opportunity to really dive deeply into the literature, because a lot of times the things we're looking into go way off of the guidelines. We're on to probably fourth and fifth line treatments for a lot of these patients. And so using students to do more of a deep dive into the literature and allow them to develop those writing skills and communication skills to write back to the psychiatrist they found has been another very meaningful part of this process. And prior to COVID-19, we met in person every week, but we were able to quickly transition over to Zoom. So we didn't really skip a beat in the last year. We've been able to meet virtually pretty much every week still to work through our list of patients. So just a few examples there. So what the future looks like, this process, I can't believe it's been almost 2 years now that I've been involved with it. And I feel like I'm still getting my feet under me. Every patient brings a new challenge and opportunity, but kind of the future of our group and maybe thinking more about how to look at this as an opportunity to also put something out there in the literature about maybe a little bit different model to provide this care for patients, being that it is a bit unique in the primary care setting. But our team is looking at implementation. We're going to be starting this actually relatively soon of reimbursement. So there are opportunities to be reimbursed for behavioral health complex care management, and I'll be involved as part of that process for tracking the amount of time we might be spending reaching out to patients to call them to verify medications or otherwise. So that's exciting that there might be some reimbursement for the team to kind of prove that value from a financial standpoint. And all the, certainly like to think that we're saving some burden on the healthcare system with keeping people out of the hospital and ED and other things like that. Also, as we move forward, we have this very powerful electronic health record that has a lot of data in it. And so actually maybe taking a closer look to see if what we're doing is making a difference, looking more at scales and scores for patients with depression or anxiety and thinking about the most appropriate outcomes to be tracking for patients who maybe have those conditions. And the last thing, I would really like to do, this is not something I've thought to do, but I think it would be really interesting to get insight from students. Their perceptions about the team, their perceptions about patients with mental health conditions in general, kind of a pre and post survey is something else I would like to kind of work towards implementing to get a sense for how students view their role on this team and how they view the care of patients with mental health conditions in general from ahead of doing this and after being a part of this process as well. So I know we're supposed to kind of keep it short and leave time for questions here. So I think that's all I had for slides, but I'm certainly happy to answer any questions that people might have, or if there's any additional information that can be shared, I'm happy to do so.
Annie had a question about the reimbursement. Where would you see the likely source of reimbursement at this point in time?
Yeah,
hopefully.
Yeah, my understanding is I think it will be for patients who have Blue Cross Blue Shield. You know, I don't think Medicaid is reimbursing for this type of service right now, and I'm not sure unless it's a Blue Cross Blue Shield Medicare plan. That's a great question. This is in its infancy with the reimbursement, so I haven't, you know, last I heard it had more to do with Blue Cross Blue Shield, which we see a substantial enough patients to probably to justify that being a good use of time to seek that out. And it comes as a bundled payment, you know, so it's kind of looking at you get a certain amount per month to manage these patients too. But I think it's Blue Cross Blue Shield is the commercial plan. That is my understanding. That would be kind of the source of the reimbursement right now.
Great.
Mm-hmm. More to come on that. That's a great question.
Hopefully, yes.
Yes, yeah. Yeah, there's always barriers. And to be honest, this was something we sat down and had a discussion about, I think about a year and a half ago. So it moves very slowly. Yep. Any other questions at this point? May not be much, which is fine.
I don't see any in the chat. I will tell you that I love this model, and as someone who has a child with who was diagnosed with epilepsy, I could have really used, you know, some interaction with the pharmacist as we went through the many medication plans that didn't work on the front end,
Yeah.
and waiting for doctors to have time to, you know, talk to us only for 5 minutes and say, oh, well, maybe you should just try this instead. It could have saved a ton of time and a lot of vomiting. So
Yeah.
I think it's a great model.
Yeah, and I think, you know, one other thing we're trying to do is to train this new group of physicians to feel more comfortable treating patients with mental health conditions, because there's just such a lack of access to resources for patients with mental health conditions, and a lot of physicians might feel uncomfortable managing some of these conditions. So just trying to increase their comfort in that too. And that's a great point though, that you know, the pharmacists often are reaching out to the patient via phone or in person to clarify meds, to what are you actually taking, like what's actually being filled, what happened with this, what happened with that, to kind of be part of that problem solving piece of all of this too. So I appreciate that feedback. That's really, thank you for that.
Yeah, I don't know if you've had a chance to speak at all with like Michael Klepser and some of the folks. We had been working on a grant application to do what you're talking about, but in the actual pharmacy space.
Oh yeah, sure.
So,
And that's a team member that I think is really important to include, as the community pharmacist. You know, because our clinic doesn't have an in-house pharmacy that we use. We're constantly reaching out to the pharmacy to help, you know, with what's covered, or, you know, cost and all of that. And I think, you know, just breaking down those barriers in the pharmacy too, from a stigma perspective, I think is helpful too. So that's a great point.
Yeah, well, if we're successful in getting this project, then we're going to be rethinking the neighborhood pharmacy model and including some of this connected care type approach, and bringing some of the folks like your social workers. We even talked about like nutritionists, dietitians, people like that. How do you bring them into the fold and provide more point of service care at a pharmacy?
Yep.
And avoid, you know, waiting to see the doctor at, you know, unless it's absolutely necessary.
Yeah, and I know, you know, community pharmacists is so hard because they don't have the access to the charts. And that, I think, is a big part of one of the barriers. But if you can break that down, I think that, I mean, absolutely, to meet people where they're at. They're in the pharmacy more than they're in the doctor's office a lot of times. So trying to help them where they're at, I think that's a great point. Yeah, absolutely.
Great. Well, we have just a couple minutes. Any other questions from the audience?
thank you everyone for tuning in,
Yes, nice
whether it was
job,
intentional or not, but thank you. Yeah.
All right,
Oh,
take
I
care.
got my screens. Yep, let me get out of here. So, there we go. Oops. There we go.
Enjoy your next session, everyone.
Thank you.
Eric, I have set you as co-host, so you're free to share your screen whenever.
Thank you. How's it been going today?
Been pretty cool. Some of the last two I've had were very, very specific, like lung cancer stuff and then like mental health pharmacy stuff. So that's way over my head. So it's interesting to learn the stuff I do, but a lot of it, they're just like, they know their audience is like, knows what they're talking about. So it's not new people friendly, to say the least.
Yeah. Don't worry, mine's on an 8th grade level.
That is perfect.